All right, everyone. So welcome to our second session in our latest series of Boosters and Beyond. Today, we're going to be talking about urinary tract infections, and we'll get started. So if you're not familiar with who we are, we're the IPRO QIN-QIO. IPRO holds the federally funded Medicare QIO contract for the 12 regions shown here. IPRO specifically covers New York, New Jersey, and Ohio. Health-Centric Advisors covers Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent covers Maryland, Delaware, and the District of Columbia. Together, we fall under the IPRO QIN-QIO and service all of these states to help support improve quality for Medicare beneficiaries. And with that, I'll pass it over to our speakers.
Hello, Josh. Can you hear me okay? This is Marcy.
We can hear you.
Okay, perfect. Thank you. Wanted to make sure we talk about the COVID vaccine and a booster update. You can see the slide on the screen. As of 9:30, 7.6 million had received their booster doses. And knowing when you are up to date and continuing to keep those booster programs going in your facilities. I know it's been hard. We have flu, we have COVID boosters. So we just want to always keep it at the front of your mind with that. Next slide, please, Josh. And then I wanted to bring up our Vax Chat series. That's in the morning, every other Thursday at 7:45. Our next one is on 11/3. Great conversation between two of our IPRO infection preventionists about all things vaccine. Anyone can get on these calls. This does not have to be IPs. It can be your staff on the floor about learning more about how to increase their vaccination rates in the staff or in your residents. So it's a great conversation, wonderful program we put on really early in the morning for maybe your night shift can jump on. Next slide, please. So our objectives that we're going to go over today, we're going to review the impact of UTI on our residents' well-being in the nursing home. We're going to review our infection prevention and control measures for reducing UTIs. We're going to discuss other best practice for reducing UTIs that might not have to do with infection prevention, but other things throughout the facilities you can work on. And we're going to identify potential interventions to implement to reduce emergency department visits and possible readmissions to the hospital, which I know is a lot of why you're all here. Next slide, please. FAQs. So will you get a copy of the slides? Yes. This presentation is being recorded. Wednesday at 3:30, there will be a replay of this as well that you can get on, and there'll be people on hand to answer questions. We do have to send the PowerPoint through 508 regulations, and once that is done, it will be linked up to the IPRO site where we post our PowerPoints, and you are welcome to pull it down from there when that's finished. Next slide, please. So our presenters today, I'm Marcy Medley. I'm one of the Clarent Quality Improvement Consultants. And we also have Darlene Shoemaker from Clarent, one of the IP consultants. We're both nurses. We work mostly in Maryland, DC, and Delaware, and with our whole IPRO team all across all our states. So we're glad to be here today with you. Next slide, please. So the problem, I kind of wanted to start here, and we've been talking about urinary tract infections for years. We have tried all kinds of different things. And this statistic really stuck out to me for a couple of reasons. So it remains one of the most frequent diagnoses in the hospitals. And we know that, and some of it's because we dipstick all the urine every time. Okay, I hear you. But this is what was super interesting to me. Early in the beginning of the 2000s, there was 1 million ED visits across the country in the US related to UTIs and 100,000 admissions. However, in this data, when it says a decade later is from 2016 to 2018, a decade later, there was a fourfold increase. So we had 400,000 hospital admissions for UTIs. It isn't talking about the ED visits here, it's talking about admissions. So people are getting sicker from this. Really scary. Why are we having more admissions? We've been talking about it, we're working on things. So we need to keep going, and that's what's important. Next slide, please. So I'm going to talk about a little about the impact of UTI on our residents here in the nursing home, but I wanted to bring up something that's a little not here on this slide, and that's why are our residents more at risk? Like, why? And we talk about this throughout the presentation, but I kind of wanted to pull these few things out for you to hear. And remember, because one of them really stuck out to me. Decreased urine flow. So we know men can have enlarged prostates. We see increased kidney stones in the elderly. The decreased flow of urine makes it harder for the good bacteria to be in the urinary tract, and then the bad bacteria can cause an infection. We have decreased mobility in our residents, so they can't get up and use the restroom as easily. Some of them have functional difficulties that they can't perform their pericare the way that they need to, even if they know how that works. So it's more difficult and for them to move around. And then, of course, you think about pain. Sometimes they just don't want to get up again. They have to go again. And so it's causing more problems. Incontinence, of course, shows increase in the elderly population, and especially bowel incontinence. Of course, the stool has a lot of bacteria. So if people are incontinent of bowel, we're going to see a much higher rate of UTI. Catheters, catheter use, we know that. I know Darlene's going to talk about catheters a little more later. Elderly patients, seniors, have a weakened immune system. As we age, our immune system is not as efficient as fighting infection. So we know they have all these things stacking up. And one that was super interesting to me, and I remembered this, but I hadn't thought about it lately, was hormonal changes. And this is important, especially in women with estrogen. And that as the drop in estrogen happens with women, throughout menopause, it makes infections more likely to occur. So a drop in estrogen causes reduced vaginal elasticity, as well as it reduces the amount of good bacteria in the vaginal canal. And both of these things playing together, along with the women anatomy, increases the risk of UTI hugely with women. And it's a good conversation point, especially with some of our younger residents that are just going through menopause, or families that don't really understand why does this increase so much when someone is not incontinent, because you don't have to have incontinence to have UTIs, and this is can be one of the main things. So on this slide with our impact to our residents, I went over some of that, but there's physical and psychological. They can have pain from the urinary problems. It can cause new incontinence, right? The frequency, they have hesitation, things happen, and it's causing new incontinence. Fevers, that's something physical we can see. The psychological, we all know this, patients get confused. Sometimes that's the first way we know that there might be a UTI happening. Hallucinations, delusions. Sometimes people go, oh, they have dementia, but that might not be it. Maybe it's an infection, something happening. The agitation or restlessness, that's big. And a lot of times that's really related to pain that our patients can't tell us. And then lethargy, that change in their usual daily habit, or things that can impact our residents. Next slide, please. So some of the IP measures, and also just some best practices for reducing UTIs. And the CDC put these out, so some things that we can do. Of course, great hand hygiene, right? We got to wash our hands before you put on the gloves, before you take after the gloves, teaching our residents that they need to perform their hand hygiene as well. Reducing incontinent episodes. So that goes a lot around toileting, helping the residents get to the toilet. Reminding, sometimes it's just a reminder, and ensuring that we're doing frequent rounding and assisting as we can with getting people to the toilet. The best that they can get up and go is helpful. Proper hygiene after toiling. So I brought up pericare. Teach the residents their own hygiene. Use your occupational therapy departments to use alternative measures for performing hygiene. Sometimes patients don't want to tell us they can't do it the way that they want to. Make sure they have the supplies and tools that they need to perform proper hygiene, and it really will help with our patients that can. That our staff has been trained, is being audited on performing hygiene the right way. I know sometimes we get in a hurry and that we're watching that, especially our IPs, people out watching, making sure that we're are doing it the right way to ensure that we're not having a problem with proper peri-care. And then changing, if patients are incontinent, assisting with changing of briefs frequently. Changing patients frequently, especially if they're incontinent of bowel or if they've had a bowel movement. As I said, that is going to increase UTIs happen.
Where's it at?
Somebody, if there we go. Thank you. So the next one, maintaining their functional status. So I know I said earlier, the more they can get up by themselves, the better they are. So keeping those restorative programs going, having those walk to dine programs, anything that you can do to keep people up, moving, able to move their arms, legs, and up and throughout your facilities are going to actually help decrease your UTIs, because most people do want to get up and go to the bathroom themselves. And the last one on here, surveillance of infections, monitoring and auditing. So if you don't know where your infections are coming from, if you don't know what bacteria is being caught in these,
go ahead and mute it back.
Yeah, thank you. I know they're having problems hearing it, sounds like.
The host has muted you. Okay, well.
Brenda, can you please mute yourself? We keep trying to mute you, but you keep coming off mute.
Okay, thanks, Josh. So the last one there, if you don't know where and how some of these infections are happening and can't explain it, then it's really hard to come up with a plan to fix it. So having a good tracking system with where UTIs are happening, what kind of patients, is it male, female, is it continent, incontinent? Do certain staff members work with them? Are it patients that eat in their rooms and might not have the best hydration, or is it people that are out and about that have better hydration? So lots of different things you can look at with your surveillance of infections. Next slide, please. And I think this is coming to Miss Darlene.
Thank you. So when we're talking about determining the best interventions to implement to reduce emergency department visits and possible readmissions, you want to make sure you're doing a root cause analysis to determine the reason for the transfer to the hospital emergency department for evaluation. You want to review the documentation for the 24 hours prior to the transfer, ask the staff what they noticed during the 24 hours prior to the transfer, and review conversations with medical staff in the 24 hours prior to the transfer. This is from an article in the Journal of American Medical Directors Association related to transfers of skilled nursing facility patients to acute care hospitals. Next slide, please. Okay, there's a list of 12 common reasons for transfer to the hospital for evaluation. And this is from an HQIC, HQIC, CCME toolkit to reduce hospital readmissions. This is a 4-page document, and each of the 12 reasons have resources and potential interventions. And Josh, if you could put that link in the chat, I'd appreciate it while I'm reading the 12 common reasons. So first is inadequate communication during handoffs from hospital to nursing home, and then lack of awareness of nursing home capabilities by hospital discharge staff, early change in residents' condition, unrecognized and unreported by frontline nursing staff, multiple signs and symptoms without specific clinical diagnosis and effective management, lack of resources necessary for the resident's condition. Next slide, please. Inadequate communication between nursing staff and the primary care provider. No in-person assessment by healthcare provider, such as a nighttime transfer. Facility and family insistence and preferences. Family calling 911 without the facility input. Inadequate advanced care directives. infection or potential sepsis, and inadequate post-fall assessment. So this 4-page document has potential interventions for each one of these areas, and I suggest you download this document, and it's a good resource. Next slide, please. So what do you do when you don't send the resident to be evaluated in the hospital emergency department? You want to make sure you treat the symptoms, such as hydration and reduced fever and pain. Determine if the symptoms meet the requirements for lab urinalysis and or cultures. And I know somebody had in the chat talked about McGear's, and whatever your facility should have some kind of policy or procedure related to which process you're using for determining the requirements to the symptoms meet the requirements for UTI. Ensure antibiotic is ordered and is appropriate for the culture results. Start the antibiotic as soon as it's available, and monitor for untoward effects of the antibiotic or drug-drug or food-drug interactions. Next slide, please. So one of the things that Marcy and I were talking about is things that have changed over the years. So any one of these interventions might have worked for one individual, but introducing the intervention to a group of residents didn't have the anticipated results. So some things that have changed that I recall was there was at one time a regulation that said a standard UACNS in the absence of symptoms was required if the resident had a diagnosis of diabetes. Another thing that happened over the years was cranberry prophylaxis, and then prophylactic antibiotics such as macrobid, and then specific supplements such as UTI stat. Marcy, can you talk about the UTI stat?
Yeah, so there are other names for it, and certainly other supplements around the same concept as this. And I wanted to be clear, and I know Darlene did too, is we're not saying that these things don't work with people, they do, but that a plan that says we're going to give all our residents in our whole facility or our whole unit this without really doing a formal assessment, that is where, if you look at the research, like if you look at even the UTI stat research from their company, that it doesn't show great results. But if you really do use the things where they do need, that it's fine. A great example is I know a resident, I still remember her, and her daughter was insistent that if mom does not have a glass of cranberry juice every day, she's going to have a UTI. And guess what? She did. And so we made sure that was part of her plan of care, but that wasn't a plan of care for every patient in our whole building. And that's how we were going to control things. So that's kind of what we were thinking here, is that things have changed. We aren't just blanketing things. We need to really assess what works for each of our residents. And some of them do work really well.
And so what we'd like you to do is either take yourself off mute or put in the chat, what are some other things that you can recall that were encouraged over the years as potential interventions for pretty much everyone? And this is where I'm like, Melody, it's really hard to not talk while we're waiting for somebody to come off mute or to put something in the chat.
You want me to start talking, Darlene? Yeah, I got to tell you, what is just triggering to me is when I, for 25 years ago, 30 years ago, when I became a nurse, if there was mental status change, get a urine. That was number one reason why we're getting urines, because somebody had mental status change.
That is a perfect one to add to our list.
Yeah, so there was a comment in chat actually from Erin Patnode. She asked if you can comment on the fact that the CDC guidance in prevention doesn't indicate altered mental status as a positive sign of UTI. Why are we teaching this, and what's the reference? We see overculturing secondary to this misunderstanding with altered mental status. Well, I'll start with that. I think what we're concerned about is that
we don't want someone who is exhibiting a change in mental status that might be related to a urinary tract infection to all of a sudden get an informal diagnosis of dementia when it really could be something else. I understand that what you're saying about inappropriate culturing, but you need to look at and pay attention to the McGeer criteria so that even though you're seeing a change, you're still using the current scientific listing of what is the components of a UTI. And
so can I just ask, I'm Erin Patnode and myself, Mary Pierce, are both watching this together in our shared office. So that is old criteria, and part of what we were trying to change in diagnosis of UTI is exactly that. So this is a really confusing, and I heard someone say this is triggering, but like it's triggering to me as well, because that is the exact opposite of what we're trying to do with UTI. So if you have altered mental status, that is not scientifically backed up anymore with regard to UTI correlation.
Correct.
Yeah, so I think maybe, and I'm just kind of doing this off the top of my head, Erin, but you're thinking about this slide about and things, or I don't even have that other one up in front of me, around physical and psychological impacts, and that there can be an impact with confusion. I agree. And just like Melanie said, we're not going to do a UA on every patient that's confused. It is a full assessment. We totally agree. And I think as Darlene moves on, maybe that will get clearer. But if not, we can talk more at the end too. But that, no, I agree. I think everyone agrees that just because someone does have some confusion does not always mean that's what it is, but it can be a sign and can impact the resident well-being if they do have a UTI. I think maybe that's where that's from. All right, Darlene, you ready?
okay, no, I'm reading it. I'm reading.
Oh,
a
you're
chart.
reading.
It's increased use of beverage carts with lemonade, increased use of cinnamon, strawberries during trending months of high UTIs. And at the time it was the summer months. I'm like, I understand the increased beverage carts.
Cinnamon,
But yeah, cinnamon was kind of unusual. I think I got
And
a little sick
strawberry.
on that.
Maybe that makes people drink more. But super interesting. Like, it's just sometimes I've never read any research on cinnamon, but no guarantee it's not there.
Right, right. Okay, Josh, next slide, please. Sorry, we kind of got off track there a little bit. Okay, one of the things that I do want to talk to you about is the critical element pathways. So this is part of the long-term care survey manual, and there's a critical element pathway for urinary catheter or urinary tract infection. And I really hope that you all have been looking at these. The link that I have is actually a link to an older version, but there have been no changes. The survey pathways were updated to include the ROP 3 Part 2 and 3 sections recently, and they became part of the survey on October 24th, 2022. So while this particular critical element pathway has not changed, there's others that did. So please pay attention to that. This particular one is CMS 20068. So when you're looking at this particular pathway, just an example, they're telling the surveyors to, during their licensed nurse interview, ask the nurse, how have you assessed and addressed factors affecting the resident's urinary function and identified the clinical rationale for use of a urinary catheter upon admission and as indicated thereafter. So this is a specific question that the critical element pathway is asking the surveyor to ask your nurse. So I just want to make sure that you're aware that that's there and then how to get to it, and that all of the survey pathways have recently been updated. Next slide, please. Okay, we need to also, when we're talking about UTI, we need to also think about education to reduce the use of indwelling urinary catheters. CDC has a very good presentation. This is a PowerPoint presentation, and it's an education tool that CDC developed for other people to use. So it talks about the appropriate use and prompt removal of indwelling urinary catheters, and it talks about common clinical scenarios and a daily checklist to reduce use of inappropriate indwelling urinary catheters. And it talks about at least one reminder or stop order strategy for removing unnecessary indwelling urinary catheters, and then 2 strategies to engage your staff. So there's 24 slide presentations, and then it's 2 slides of references. And then after that, it's the speaker notes so that anyone can use this presentation in any kind of small group of staff. So next slide, please. IPRO is developing an action plan for reducing hospital readmissions due to urinary tract infections, and it's currently in its final review. Let me just tell you a little bit about this action plan that we have. It includes SMART goals, baseline measurements, boundaries of the project or the PIP, resources, barriers to appropriate completion of the plan, and strategies to act on those barriers, action steps, differential diagnosis, UTI definitions, identifying complicated UTIs, education pre and post tests, and references. So please put your name in and your name and email in the chat if you would like us to send you the action plan. It's currently going through its final review, and as soon as we have it finished, we'll be sending it out. Okay, and next slide. So how to use the action plan. You want to identify the team who will work on the performance improvement plan. And then the action plan that we've generated includes many types of interventions. What you want to do is select the intervention that matches the outcome of your root cause analysis that we talked about, I don't know how many slides ago. Determine the specific area for implementing the intervention. So what are you going to do, the whole facility? Are you going to do a unit? Are you going to do a small group of recent admissions? Then monitor the data. So you're looking at the infections, the transfers to the hospital emergency department, any readmissions to the hospital emergency department prior to the implementation, and then after the intervention has been in place. Next slide, please. So what has worked in your facility? Share your successes in the chat or unmute and share. So we have a really large group. So somebody probably is working on reducing hospital readmissions related to urinary tract infections, or just reducing urinary tract infections within the facility.
Well, I'm just going to say what we were just talking about a couple of minutes ago with when Aaron said they're trying to change the mindset in where they work, that every time someone's confused, you don't just do a UA. Is anyone doing anything else that is working in your centers that you're seeing that's different?
Or do you have an education plan for either your unlicensed staff or your licensed staff that seems to be working, that all of a sudden you can see people having an aha moment, like, oh yeah, okay, I understand why our first step isn't getting urine. Okay. You're going too fast. I missed the comment. Let me go back up. Josh, can you see it? It was something about a dipstick.
I will scroll up, but Susan, while I'm looking for that, Susan shared that we recently started using urine PCR testing, which provides results within 24 hours, so treatment can be initiated faster.
Urine PCR testing is really nice technology. Anybody else using that? It is really nice, and it doesn't take so long to get this stuff back from the lab. I know a lot of it's not super readily available to everyone all the time, or expensive.
And Melanie had shared earlier in response to Erin about the she said that McGear's criteria supports constitutional criteria, which allows for acute mental status change from baseline to be part of the decision making, but is not an independent factor at all.
Well, and actually, I'll just specify that actually only says that in the case of someone who has a chronic indwelling urinary catheter. It's not in the absence of someone with a chronic indwelling urinary catheter.
Okay, Lori says we've educated our frontline nurses to watch for signs and symptoms of UTIs and improve their documentation of the observation. This helps medical determine treatment plans. And there's a question about how is the accuracy? Marcy, I guess that's for the urine PCR.
Yeah, I don't know off the top of my head. I know someone had said they had started doing it. As far as I know, it's, that it looked really good. I just know it's expensive.
Okay, Diane
At
says,
this time.
Yeah, Diane says we have an IDT with med director every transfer to the hospital each week to look for any opportunities. We have added a catheter care basket to each resident room on a unit to have all pertinent supplies readily available for the staff.
Well, Darlene, I think that's the perfect segue to your next slide, Josh, if you want to move it, because it's about that.
So we're talking about reducing the number of transfers to the hospital emergency department in general. So some of the things, just like the commenter said, rounds at the end of the week to identify potential changes in resident health, and calls to the covering medical practitioner to review resident current status. And then some facilities are able to use telehealth. Okay, next slide. So we have a couple of education tools. This first one is called Diagnosing the Elderly. It's Not Always UTI. This is from a different QIO, and it's a 4-page document, and it can be used as an education tool. There's some parts of it that's really focused on talking to nurses. There's some of it that can be used for all staff. And then there's another tool that's South Carolina UTI Toolkit for Long-Term Care Facilities that's still current. Next slide. And here's some additional potential tools that you can use. Interventions to reduce urinary tract infections in nursing home residents, and education for nursing home nursing assistants through the Minnesota Department of Health, and a toolkit for reducing catheter-associated urinary tract infections in hospital units. Even though it's for the hospital, it's a very good guide. We have to wait for Josh. He's doing some
Yeah, I'm
things.
giving some links for all the tools.
Thank you.
And I'm putting that in now. And we also have a link to a survey that I would like everyone to fill out if they have an opportunity. Specifically, CMS had coordinated with the QIOs to work on collecting information related to COVID-19 and emergency preparedness for your building, so that we can then follow up based on your responses with education and technical support. So if you have a couple minutes, if you could just fill out this Survey Monkey for COVID bundle. It has questions related to COVID-19 and emergency preparedness for your building. It would be really helpful for us if you were able to fill that out. And at this point, the formal part of the presentation is over, but we'd love to have you all unmute yourselves, put more questions into chat so that we can discuss with you today's topic.
Somebody said something about the AHQR link doesn't go to a current page. I'll work on that and we'll get it posted, okay?
Try that link. Toolkit to reduce quality in other HAIs and long-term care facilities.
Thank you.
That one worked, Melanie. Thank you. Mike had a question. Can you explain left band shift?
Melanie, is that something we could take to IP3?
Yes, I think, Mike, that would be a good one to talk about in IP3 and be prepared to answer more of those questions. Thank you.
All right, well, I'm not seeing anything else in chat or anyone else is coming off mute. So wanted to share our contact information. You can always contact us if you have any questions or need any tools or resources or any support. Our contact information is shown here. So please take a moment to make sure you have us. And with that, we'll end this session for today. Thank you so much, everyone.